Okay, so good afternoon, everyone. This is a discussion of our drugs that affect our respiratory system. Now, this is our first, for those of you who are unaware, this is our first semi-final topic. Ayan, no? So, we have already crossed the threshold. Now, this is our first semi-final topic. And we are gonna discuss respiratory drugs, no? Which include the following: drugs for the upper respiratory disorders and drugs for the lower respiratory disorders. Now, the good part about respiratory drugs is that they are very cross-compatible. Meaning to say, class, no, drugs that are used for the upper respiratory disorders are usually, what we call it, they can be used for most upper respiratory disorders, no? And how I'm gonna emphasize that is usually I'm gonna use one specific disease process, no, in order to show you the cross compatibility of these drugs, no. Now, here are our drug classifications currently. So far there are 9, no. There are 9. However, ang kini atong mucolytics class, our mucolytics and our cromolyn sodium. I want you to read about this, no, because they're very short, no, very short. So this is our further reading na. This is our further reading. Okay? Another thing that you need to note here is that this is actually missing one specific drug. And that drug is oxygen, no? Oxygen or oxygen administration. Because class, typically speaking, when we say oxygen, it is a prescribed drug, no? Oxygen is a prescribed drug, if you don't know. However, class, the complexity of delivery, because there are lots of ways to deliver oxygen, class, no? Like for example, there is a way to use a cannula, while others will use a venturi mask, while others will even use a hyperbaric chamber, no? The complexity of delivery necessitates that it is discussed in your med-surg. Okay? Actually, class, that is the first return demonstration for med-surg, no? Oxygenation and oxygen administration, no? The complexity, mga good class, no? There's lots of things to talk about when it comes to oxygenation. Okay. Now, another thing to note, no? For all the drugs here, it is essential that you monitor the patient's respiratory rate, auscultate lung sounds, and O2 saturation. That is for all drugs, here. Before and during administration. Okay? Before and during administration, before you give these drugs, no? And another thing you need to take note when it comes to all these drugs is, for all drugs, no, alleviate anxiety, okay, of the patient before administering. Why? No? Why? Because anxiety typically increases your respiratory rate. Okay? And sometimes, no, the effectiveness of the drug is affected when there is an increase in respiratory rate. Okay, so let's talk about our upper respiratory drugs first, no? Here we have 4 classifications. Now, typically, class, okay, the disease process that I'm gonna talk about to exemplify the action of these drugs is rhinitis, no? Now, what is rhinitis, class? Rhinitis, okay, this is inflammation of the mucous membranes. Inflammation of the mucous membranes of the nose, no, of the nose, no. Typically, class, there are two etiologies, no? Typically, when it comes to rhinitis, there is two etiologies. The first one, class, okay? Wait, bati. Yan. The first one is what we call our acute rhinitis. This is caused by rhinovirus. Rhinovirus, no? Oftentimes this is called your common cold, no? Common cold. The other cause for our rhinitis is what we call allergic rhinitis, no? This is very common, class. Actually, I actually have this, no? As you can see right now, I am having nasal congestion, no? This is often caused by an allergen, no? Allergic rhinitis, okay? Allergens such as pollen, dust, no? What else? What others? Pet dander, like pet dander. Ayan, no? So those are example of our what we call allergens, okay? Now, what are the signs and symptoms, class? Okay, what are the signs and symptoms? Now, here's the thing I want you to keep in mind. Most of these drugs, actually all of these drugs, no, they typically target one of the signs and symptoms. Now, I will show you, I will show you. Okay, listen. The first sign and symptom is rhinorrhea. Rhinorrhea. This is often called a watery nasal discharge. Okay, watery nasal discharge, no? Typically this is clear in color, no? Clear in color. The second one is nasal congestion. Nasal congestion. Nasal congestion is the pooling of mucosal secretions. Okay, mucosal secretions, no? Cough, narrowed airways, also called your bronchospasms. Okay, also called your bronchoconstriction. Ayan. And another is increased mucosal secretions. Okay, when we say mucosal secretions and watery discharge, they are the same, no? Now, what I mean by that is simple, class. What I mean by what I said before is simple. Antihistamines, class, the way they act on rhinitis is that antihistamines, magod, typically they prevent, no? They stop histamine. So if they stop histamine, magod, they will stop the inflammatory process, no? They will stop inflammation. Okay. They are also very effective when it comes to bronchodilation, no? So they are also bronchodilators. Ayan. So they are good for our narrowed airways, di ba? Our nasal congestions, these are for nasal congestion, decongestants. No? Our antitussives, they are responsible for stopping cough, di ba? Stopping cough, no? And our expectorants, they are for increased mucus secretions, and they are also for nasal congestion. So they actually have they will affect, no, most of our signs and symptoms, no? The thing is this, the thing I want you to remember is this, tanawa, if the rhinorrhea, if the watery discharge has a different color, let's say for example, class, yellow green ang imong tiluka, no? Yellow green, or consistency, let's say it is thick, no? It is thick, then it is probably caused by bacterial infection. In this case, class, you do not need any of these drugs. You need an antibiotic. The first topic of our pharmacology, antibiotic. Ayan, no? So let's talk about our antihistamines, okay? Now, normally speaking, no, the release of histamine is triggered by allergens, no? So when pet dander or dust or fomites or what else, or pollen enters your system, then your body will release histamine. Now, the problem there is this. Now, there are two types of histamine, histamine 1 and histamine 2. We will focus on histamine 1, okay? So, class, I want you to disregard, class, histamine 2. Okay, disregard histamine 2. Because histamine 2, class, is more on the GI or gastrointestinal. Oh, gastrointestinal. I am just putting it here so that you know that there is a different type of histamine. Okay? Okay. Now, histamine 1 class is found in most extravascular smooth muscles. Okay? Extravascular smooth muscles, no? And when they are activated, okay? If they are activated, no? If they are activated, then they will cause allergy-like symptoms, no? What do you mean when we say allergy-like symptoms? What I mean by that is they will cause inflammation. We already know what inflammation is, di ba? And bronchoconstriction. Now remember, bronchoconstriction can narrow your airways. No? It can it can make your airways smaller, no? So, what an antihistamine does, from the name itself, class, is as H1 blockers, they will compete with the H1 receptors to block the action of histamine 1. So it's like this. If the one in red is your histamine, listen to me ha. If the one in red is your histamine, no? And then the one in yellow is your receptors. No, parang ganyan. Parang it's like a Y. Those are your histamine receptors, no? Your antihistamines, no? Your antihistamines, the one in blue that we will draw in blue, no? What they will do is they will try to compete. They will try to go to the receptors, no? So that the histamine cannot enter the receptors. So that the histamine cannot enter the receptors. Therefore, blocking histamine 1 effect. And remember, sa itong effect sa histamine 1, no? Inflammation and bronchoconstriction. Now, if you block histamine 1, okay, so there will be no allergy symptoms. Instead of bronchoconstriction, class, what will happen is there will be bronchodilation, which is very good because our diseases, like for example, rhinitis, often causes what we call narrowed airways, no? And it can also stop inflammation, diba? Which is very good, no? So that is the mechanism of action for our antihistamines, okay? Now, most antihistamines, no? Most antihistamines, yan, are absorbed in over 15 minutes. Okay, they are absorbed in over 15 minutes. However, class, they are not effective. However, they are not effective for anaphylaxis. When we say anaphylaxis, this is a severe allergic reaction. Okay, this is a severe allergic reaction, which often closes the airway, and that is a big problem, class. No, closing the airway. So if you close the airway, you can't breathe. Man, good. They are not effective, class, because they are not potent bronchodilators. Okay, they are not potent bronchodilators. They have a bronchodilating effect, but they are not that strong. No, they are not that strong. So that's the thing about our antihistamines. Okay. There are two generations, class, of antihistamine. There are two generations of antihistamine. Our first generation and our second generation. No, the thing you need to know about antihistamines and the two generations is that our first generation muna siya mga drugs, diphenhydramine, chlorpheniramine, and doxylamine. Our second generation, cetirizine. We already know cetirizine, very common. Fexofenadine, loratadine, and azelastine. Now, these are our example drugs. Now, the main difference between the two is that first generation is mildly sedative. It has the effect of drowsiness. No, it has the effect of drowsiness. While the second generation does not. No, the second generation does not. Another thing to consider is that both of them have anticholinergic effects. Okay? Now listen to me, ha. When we say, as I mentioned before, when we say cholinergic, we are referring to our parasympathetic nervous system. Okay? Now, usually, our parasympathetic, we call this our rest and digest, no? Typically, they will increase, no? Typically, the activation of your PNS will increase urine output. It will increase defecation, no? Kanang malibang. And it will increase, it will decrease, no? The heart rate and decrease the blood pressure and respiratory rate, no? Decrease na siya. It's all decreased, no? However, okay, antihistamines have an anticholinergic effect. So, instead of activating the PNS, it will activate your SNS activation. Okay? Because the SNS is activated, class, the opposite effects will happen. So, instead of increased defecation, there will be constipation. There will be urinary retention. And here's another thing that is very crucial, class, no? Decreased secretions. Okay? Now, this is very good, no? Most other things, they are, I wouldn't say potentially harmful side effects, but they are irritating side effects. However, decreased secretions, class, is a good side effect because they will help decrease secretions in rhinitis. Diba? If you remember from what I said before, no? Rhinitis has what we call increased mucosal secretion. So, the side effect of antihistamines, which is anticholinergic effect, also decreases the secretions in rhinitis. Okay? Here's the thing you need to remember about the second generation. Okay? The first three, they are typically used short term. Okay? Short term. And the reason why is because their half-life is around 7 to 15 hours. While azelastine usually is given long term because its half-life is around 22 hours. Ayan, no? Very simple, class. The difference between the two, I want you to remember this, is drowsiness and mild sedation for the first generation. The rest is basically the same. The drug names lang ang different, no? So, what we need to consider, okay? Number 1, avoid driving, operating heavy machinery. This is especially crucial, class. This is especially crucial, no, in our first generation because of the mild sedative effect, because of the drowsiness, no? We don't want that, class. We don't want them to be drowsy while they are driving, no? Muna siya, no? Institute fall risk safety measures. When we say fall risk safety measures, this is also for our first generation. No, this is also for our first generation. So, kining atong diphenhydramine, chlorpheniramine, and doxylamine. No, actually, class, you will see this in your, if you look at the drug, no? Like, let's say diphenhydramine, you will see this is drowsy, no? Drowsy, so not necessarily it's there, no? So, what are our fall risk measures? We already know this, no? Balik-balik na lang ta. Attach call lights. No, what else? No, raise side rails. Ayan. What else? May manindot, no? Remove environmental hazards. hazards. Like for example, throw rugs. Throw rugs. Ay. Throw rugs, no? Okay, wait. Throw rugs. And another is loose furniture. Like for example, class ka ng mga small chairs. No, small chairs, small tables. Another is ensure adequate lighting. Adequate lighting. Yeah, kini class, I often forget to add this, no? Assess. Okay, Romberg's test. Romberg's test. If you remember, Romberg's test is our balance test, no? The reason why we institute fall risk is because, remember, the first generation drowsiness, it also has dizziness. Okay? Dizziness. No, dizziness. No, when we say drowsiness, magud accompanying that is dizziness, no? Instruct the patient to avoid CNS depressants, drug, and alcohol. Okay? CNS depressant, drug, and alcohol. So, kung sa man na siya class, what do we mean by that, no? It's the reason why is because if you this drug manggod class antihistamines, okay? Okay, antihistamines manggod, no? Plus our CNS depressants or alcohol can cause what we call respiratory depression. Okay, respiratory depression, no? And we don't want that class. No, respiratory depression, usually the RR is less than 12 cycles per minute, no? So, well, if this happens, no, we need to stop giving the drug na. Okay? We need to administer oxygen na at this point, no? If the RR is less than 12, no? You need to intervene for the following side effects: dry mouth, blurred vision, and gastrointestinal disease. No, for dry mouth, what you need to do is to provide oral care. What else? No, you can rinse the mouth. No, usually what we use is a non-alcoholic mouthwash. Okay, like a saline mouthwash. And dry mouth man. So, to increase salivation, para daghan og saliva, give a sugarless gum. Okay, lagyan mo yan ng malaking star class, give a sugarless gum. No? For blurred vision and dizziness, we need to do our fall safety risk measures. We already know what that is, no? Fall safety risk measures. And for gastrointestinal distress, the first step that you should do, is to assess. Okay? Assess what type of distress. Usually, class, it is pain. However, class, there are two types of pain usually accompanied with our what we call antihistamines, no? If sharp gani class, if the pain is sharp, no, then what you need to do is you need to provide saltine crackers. Okay? Kanang like for example, class, saltine crackers like Skyflakes, no? Bland foods. The reason why is because if we go back here, no, sometimes mga good class, our antihistamines has what we call a residual effect, no? Sometimes our antihistamine will also block they will also block histamine 2. And if you block histamine 2, there will be decreased secretion of gastric acids, and there will be a decrease in hydrochloric acid. No? So if there is a decrease in hydrochloric acid, mga good class, there is a what we call rebounding effect, wherein the rest of the other mechanisms that increases your hydrochloric acid, if will increase. So sharp pain typically refers to a hyperacidity. What we need to do is we need to give saltine crackers to decrease that, no? If the pain is aching, okay, kapati sa blue. If aching pain, if it is aching, then what we need to do is we need to switch diet. Switch diet, because that is an incompatibility of the diet, no? Now this is what we call now your depends on MD and nutritionist, which diet they will give, no? Oftentimes it's bland diet, sometimes it's that diet is tolerated, no? What are our contraindications for antihistamine? This is contraindicated for patients with glaucoma. Okay, now for those of you who don't know, no, glaucoma is gradual vision loss due to increased intraocular pressure. Ayan, no? Now, this is contraindicated for patients with glaucoma because the anticholinergic effect increases the blood pressure. Okay, remember, anticholinergic effect causes an SNS or sympathetic nervous system response, which increases the blood pressure and also increases the IOP. Now, if you add that increased IOP to your already increased IOP in glaucoma, then it will make glaucoma worse, no? Faster progression, no? So we don't want to give this. This is also contraindicated in patients with benign prostatic hyperplasia. Now, what happens, mga good class, in benign prostatic hyperplasia is that your prostate is enlarged, no? Enlarged prostate. Okay, now if it's like this, if this is your urethra, your prostate class is the organ that is around your urethra. Okay, around your urethra, or urethra, no? What happens, mga good class, remember, above your urethra is your bladder, no? Your bladder na siya dire, just like that, no? It's your bladder. Your bladder is full of urine. Okay, your bladder is full of urine. Now, what happens, mga good class, in benign prostatic hyperplasia is that this will swell, no? Ang imong prostate, it will swell. And because of that swelling, class, it will compress, no? It will compress. Mura siya iapiiton. It will compress the urethra. Okay? And because it is compressed, class, urine, no? Urine, since it is very now compressed, huot na kaya na siya, class, there will be a decrease in urine output na, no? There is a possibility that urine might not even pass, no? Sometimes inanibot nga og catheter, no? So patients with BPH already often have urinary retention. And remember our anticholinergic effect. One of its effects is that it will decrease. Ato kitaon rio, if nangilad ko, no, asa to anticholinergic effect. Dera. Anticholinergic effects, one of the main things is urinary retention. When we say urinary retention, that is a decrease in urine output, no? That is a decrease in urine output. So the urine output niya, remember, naanay urinary retention, patients with BPH already have urinary retention. So what happens is there will be a lot of urine that is unable to exit, no, inside your bladder. And if there is decreased urinary output and there is urinary retention, what happens is there will be what we call our bladder wait, I have to look it up. There's a specific term, no? Bladder distension. Okay, bladder distension, which is the increase in bladder size due to retention of urine. Now this is very bad, no, because if this persists, no, if your bladder keeps on increasing its size because you cannot urinate, then it might explode. It might explode, no, it might open up magisi, no, and that's very bad. We don't want that, class, no. So that's why we don't give it to patients with benign prostatic hyperplasia. Next is our nasal decongestions. Now, here's the pathophysiology before we discuss the drug, no? Here's the pathophysiology of congestion. Okay? Infection, inflammation, or allergy can cause the dilation of nasal blood vessels. Okay? And since, remember, what I told you about dilation. Dilation can often cause leakage. Okay? Leakage, no? Specifically into your interstitial space. In the previous examples, I used swelling. Okay? Now, leakage of fluid into the tissue spaces, no, which in turn will cause swelling of the nasal cavity or pooling of fluids and a runny nose. No, because the fluid now is inside, no, or outside your, technically speaking, in the diameter of your airways. No, it is inside the, it is outside the diameter of the airways. No, so. Kumbaga, if this is your airway, if this is the diameter of your airway, what happens is the fluid in your blood will leak out, no? So there will be lots of fluid na in your airway. We call that our mucus, diba? We call that our mucus, no? And sometimes, mga good class, they are not excreted. Dili sila kagawas, no? They are not excreted well to the point that they are what we call retained, no? Retained in your airway. And the more fluids, class, the more mga good fluids, class, no? The smaller the size of the airway. So there will be what we call restriction of movement, no, restriction of airway movement, no. So that's very bad, no. Swelling in the nasal cavity will cause pooling of fluids and a runny nose, diba? Runny nose. And because of these two, class, no, this will cause restriction of airway. Restriction of airway movement. Ayan. Restriction of airway movement. Dili na makasulod ang hangin kay gamay naman lang ang diameter, no? So, our nasal decongestants, class, what they do is they will stimulate our alpha adrenergic receptors. Remember, our alpha adrenergic receptors, specifically, they will stimulate your alpha 1. Now, if you remember, class, our alpha 1 has an effect on our blood vessels. Okay? Blood vessels. What they will do, class, is they will, they will vasoconstrict, no? Vasoconstrict, no? Now, if they vasoconstrict, class, no? Vasoconstriction of the nasal blood vessels will lead to a decrease in leakage of fluid into fluid spaces, and therefore, no? And therefore, decreasing nasal or mucosal secretions. Okay? And since there is decreased secretions, na there is no longer congestion. Okay? So what are our examples of these drugs, class? Okay, drug examples. First is our ephedrine. Ephedrine. Okay? Another is our pseudoephedrine. And another is our phenylephrine. Okay? Phenylephrine. No? In the US, okay? In the US, ephedrine and pseudoephedrine, I'm just gonna say this as fact, no? In the US, ephedrine and pseudoephedrine, they are being monitored closely by the Food and Drug Administration and the Drug Enforcement Agency. Because ephedrine and pseudoephedrine are principal or main ingredients for creating a certain illegal drug. Okay? So gibantayan gina siya, class, no? Gibantayan gina siya. That's the reason why, class, most of the time if you buy ephedrine or pseudoephedrine in the US, they will limit it. Grabe kasi limit ana, class, no? Oh, so what do you need to remember when it comes to these drugs aside from unsa may iyang kuan, no? What is major legal implication? Number 1 is that usually administered. These are usually administered Okay? I-zoom out din para makakita mo. Ayan. Usually administered via nasal spray. Nasal spray. Or nasal drops. Ayan, nasal drops. Nasal drops. No? This can be also administered, can also be given via tablet and capsule. However, most of the time, class, nasal drop yun na siya, class. No, most of the time. The thing you need to remember is this, no? Frequent use. Kada bitong you are using it a lot, no? Frequent use causes what we call rebound nasal congestion. Okay? Rebound nasal congestion. Okay? This is due to sudden vasodilation. So muna siya, sudden vasodilation. And the thing is, another thing that you need to remember is this can be combined with antihistamines, okay, and antitussives for cold, no? So this one, class, nasal decongestions, no, their main action is to decrease, to decrease mucosal secretions, mucosal or nasal secretions, no? Nasal mucus mo na, di ba? So what do we need to consider? Number one, watch out for nervousness, restlessness, and palpitation. No? The thing you need to remember about that is normally this is just normal side. All of this, not just nervousness. No, all of these, no. These are normal, but needs monitoring. Okay, needs monitoring, class. That's one, class, no? Because typically, class, if you are gonna give it via nasal spray or drops, especially this drug, nasal decongestants, there are very, very few what we call side effects, no? For palpitations, class, I just want to highlight this, no? Palpitations or sudden increases in heart rate that is felt. The thing you need to remember is avoid caffeine. Okay? Avoid dark chocolate. And avoid smoking. Okay, lagyan mo yan ng malaking star because all of them can increase the risk for palpitations, no? Emphasize the limited use of nasal sprays or drops because, as I've said before, an overuse can cause rebound nasal congestion. Remember, rebound nasal congestion increases mucosal secretions and we don't want that. No, we don't want that. Malaki ang X, no? So, typically, class, when we say limited use, it is limited to 7 days or less. 7 days or less, okay? Monitor the patient's BP, blood sugar, and urine output because alpha-adrenergic drugs increase BP, blood sugar, and decrease urine output, no? Kini man siya, class, these drugs, they are alpha-adrenergic. As you can see, they stimulate the alpha-adrenergic receptors. Our nasal decongestants stimulate the alpha-adrenergic receptors, no? So they are also alpha-adrenergic drugs, no? Because of that, class, no? Because of that, we need to avoid giving this to patients with hypertension and diabetes mellitus. Okay, guys, can you give me 1 minute? Wait, ha? Okay. So that's the thing you need to remember, no? About our what we call nasal decongestants. Another is that pseudoephedrine tends to decrease the effect of beta blockers. No, pseudoephedrine tends to decrease the effect of beta blockers. No, so notify the doctor if you see this drug to drug interaction occur. What I mean by that is if you see these two drugs in the chart, then you need to tell the doctor. No, bantay siya. Doc, you are giving the patient metoprolol and you are also giving them pseudoephedrine. So, doc, maybe the pseudoephedrine will decrease the effect of the beta blocker. So you need to tell them that so that they can change the drug, so that they can change drug regimen, di ba? Okay? So taga na nakaso ka ng mga drug to drug interactions. Another is nasal decongestant should not be taken with our monoamine oxidase inhibitors or MAOIs. Okay? Unsa man dining MAOIs class? What are MAOIs? No, they are not, dili na siya maong friend ni Moana class ha. MAOIs are antidepressants, no? They are antidepressants. Okay? The reason why we do not give this with our nasal decongestant, and remember, I will put a big star on it, okay? MAOIs plus nasal decongestants cause hypertension. Actually, class, not just hypertension, class, hypertensive crisis. Hypertensive crisis, no? Katong SBP. SBP over 180. Okay? And or cardiac dysrhythmia, no? So, class, do not give this, ha? This is a major thing you need to remember. Major thing you need to remember. Ayaw nyo yung wag nyong kalimutan, class, okay? Wag nyong kalimutan yan, okay? Next is our antitussives. Now, when we say antitussives, class, these are drugs that will, listen to me, ha? Drugs that stop coughing. Okay? Or otherwise known as your cough reflex. Okay? Now, what is cough? No, cough is a naturally protective way to clear the airway of secretions or mucosal secretions. However, soreness of the throat may also cause coughing due to irritation. Okay, so that's the thing. Coughing is good because coughing will expel your secretions. It will let it out. Okay? Let it out, no? Now, typically speaking, there are two types of cough. Okay? The first is our productive cough. When we say productive cough, this is cough wherein secretions are expelled. Manggawas, class, ang imong secretions, no? So typically speaking, this is wet, no? This is what we call wet cough. Okay? We also have what we call our non-productive, which is what we call, this is where secretions, no, are not expelled. Very simple distinction, no? This is called your dry cough. Kanang dry cough, kanang mura bitag way tilok ka, no? When we say antitussives, remember, they will stop coughing. Okay? Now, mayroon ka na ko, sir, why do we need to stop coughing? I thought you said that coughing is a protective way of clearing the airway. No? Now, class, listen to me, ha? In rhinitis, mungod class, when we say that rhinitis can cause coughing, the problem there is too much coughing. The problem is there is too much coughing, and too much coughing, class, can damage the airway epithelia. No? It can damage the airway epithelia. Now, we want to, when we say antitussives, class, it is not necessarily to stop coughing itself. It is to limit coughing. Okay? no? They act on the cough control center in the medulla to suppress or stop the cough replication. When we say suppress, class, slow down lang. There is not necessarily stop, no? It depends on the strength, okay? Now, typically speaking, class, there are two types, no? There are two types, no? And I will show you there. We have our opioid antitussives and our non-opioid, okay? Now, what is the difference between the two? When we say opioid, mga good class, they are part of the opiate family, no? So, typically speaking, these are what we call our narcotic antitussives, and they cause CNS depression. Okay, they cause CNS depression. So, because of that, class, listen to me, there is a risk for respiratory depression. Because remember, okay, your breathing is controlled by your medulla found in your central nervous system. If you stop or if you slow down the CNS, then you will also slow down your breathing, diba? The thing here is that there will be positive drowsiness and dizziness. So there will be drowsiness and dizziness, okay? And this include our codeine, our hydrocodone, our folcodeine, no? These are opioid antitussives, okay? Or otherwise known as your narcotic antitussives, okay? Narcotic antitussives. We also have on our other side, class, our non-opioid antitussives, no? Our non-opioid, since they are not part of the opioid family, there is no CNS depression. Ayan, very good, no? However, they are still positive for drowsiness and dizziness, no? They are still positive for drowsiness and dizziness. Okay, ayan. So, what's the benefit, man, class? What's the benefit of our opioid? No, sometimes, class, we use our opioid because it's much more effective as opposed to your non-opioid. Because if you sleep, mga good class, if you sleep, okay, because of the drowsiness, no, because of the CNS depression, all of them can cause you to sleep, no? If you sleep, mga good class, there is a higher chance that the effect, mga good, is potentiated or made stronger, no? So our non-opioid, our non-opioid include our dextromethorphan, benzonatate, our diphenhydramine. These are very familiar drugs, no? Our ipratropium bromide, our mugoistin, and our levodoproprisin. Now the thing is, sometimes opioid and non-opioid drugs are combined, okay? Sometimes they are combined, so keep that in mind, okay? Now, what are our nursing considerations? First, with our opioid type, okay? Stop the drug, giving the drug if the respiratory rate is less than 12 cycles per minute or the BP is less than 80 systolic beats per minute, no? This is because, as I mentioned before, opioids can cause CNS depression, which also depress the respiratory system. And if you depress the respiratory system, what happens is there will be a decrease in RR. And if you give opioids, if you continue giving, then it will keep on decreasing the RR until it will stop breathing. Okay, so that is a big problem. That's why if the respiratory rate is less than 12, then you stop the drug. Okay, stop giving the drug and notify the doctor, no? Stop the drug and notify the doctor. Opioids can also cause hypotension, so do not give this if the BP is less than 80. Okay? This is contraindicated in patients with COPD and asthma. Okay? The reason why is this. This is quite complex, class, ha? The reason why is this, okay? COPD and asthma, class, they are what we consider our restrictive airway diseases. Chronic restrictive airway diseases, no? And typically, class, pabina muna ko, ha? And typically, what happens here in our what we call COPD in our asthma, is that they will retain, they have a tendency to retain carbon dioxide, CO2. They have a tendency to retain CO2. Now, the problem there is this, no? To compensate, okay? To compensate, the body increases respiratory rate. To compensate, the body increases respiratory rate so that there will be an increase in CO2 excretion. Okay, mo na siya normal sa COPD and asthma, no? So that's the reason why in asthma, because you will see them having dyspnea, very fast breathing, no? Now, the thing is, since these drugs, okay, since I will put it in green, since these drugs cause respiratory depression, okay, when you give this to a patient with COPD, then they are no longer able to compensate. In turn, they will have a decrease in O2 excretion. And if there is a lot of CO2 in the body, then the problem there is now it might cause respiratory acidosis. Ayan, no? So that's why we don't give this, no? Because it will stop the compensatory mechanism of the body, no? Respiratory mechanism. What else? No, prepare the antidote. Now, since this is an opioid class, remember the antidote for opioids is your naloxone. I hope you still remember this class niyo, naloxone. Okay, prepare this on the bedside when you are giving this drug. Instruct the patient to avoid respiratory irritants and alcohol. Cigarette smoke, occupational fumes. These are respiratory irritants that will cause considerable damage to your respiratory system. And another thing is alcohol can cause further CNS depression. So we don't want to combine alcohol with our opioid type antitussives, no? We also have our non-opioid type. What we need to do, very simple class when it comes to our non-opioid. Instruct the patient to seek medical care if the cough lasts longer than 1 week. It means to say that the antitussive is not effective, okay? And it may need readjustment, okay? It may need readjustment. Now, typically speaking, listen to me, typically speaking, no? When we are talking about our antitussives class, they are used mostly for non-productive cough. Okay? Non-productive cough. But they are also used for productive cough. But mostly, it's for non-productive cough. Okay? Non-productive, no? I want to highlight this. Okay? Ang problema ko na non-productive is since this is dry, it has a higher risk of damaging your airways. Okay? So, padayon ta. If fever and rash are present, then notify the MD. Notify MD because these are signs of infection. Okay. And then they might need antibiotics. Okay, or antivirals depending on what is the cause, no? Watch out for drowsiness and dizziness. This applies to both types. So, remember, fall precaution and instruct the patient to avoid driving or operating heavy machinery. Diba? We already know this. Balik-balik na lang taan ni class, diba? Next is our expectorant. Okay? Expectorant. Now, when we say expectorant class, their job is to loosen bronchial, mucosal secretions to easily expel them. Okay? The thing is, mga good class, if the secretions are very thick, then the problem is that the secretions are very thick, no? The problem is it's very hard to expel them because they are very heavy. So we want to make the secretions thinner. And that is exactly the action, no? The action of expectorants is they will loosen bronchial secretion by reducing viscosity, making them thinner. Okay? Making them thinner in viscosity so that they are easily eliminated by coughing. Now, the best, listen to me ha, the best expectorant, I will put it in yellow so that I will maklaro. I think blue is the best. The best expectorant is water. Okay? Otherwise known as hydration or drinking lots of water. That is the best. No? Commonly, class, you combine with other expectorants. No? Like for example, class, our two expectorants, we have our guiafenicin, or otherwise known as robitussin, and our guiafenicin plus dextromethorphan. No? Dextromethorphan. Now, unsa ragon ng dextromethorphan, class, if you remember, dextromethorphan is an antitussive. So sometimes we combine an expectorant plus antitussive. This is our robitussin DM. No? Robitussin DM. This is combination drug. Okay? Class, when we say expectorant, class, this is ideally given ideally given for patients with non-productive cough. Okay? Remember, because non-productive cough, the problem there is it cannot expel secretions. So what we need to do is we need to thin those secretions out so that they are very easily expelled. Okay? Now, expectorants, class, do not have a lot of side effects. They typically have the basic side effects, no? Nausea and vomiting. And headache, no? So katong big three, balik-balik ng mga side effects, no? They are usually the side effects for our expectorants. Now, what are our nursing considerations? No, assess lung sounds before administering. I want to put a big star on this. Typically, class, we want to give this drug. Okay? We want to give this drug if there is positive fluids. Okay? Fluids or secretions in the lungs. Okay? And we can determine that if we auscultate and find crackles. Remember, crackles, okay, also known as your rails, they indicate that there is fluid inside your lungs. Okay? Check medical records for possible polypharmacy. When we say polypharmacy, class, this is overprescription. Okay? So, since this drug is often combined with others, check for redundancy. Like for example, class, check if this is what we call combined in other drugs, and you might be giving it twice, no? Or you might be giving it 3 times, or maybe this is prescribed a lot already, no? So that is polypharmacy, no? Increase oral fluid intake, because as I mentioned before, water is the best expectorant, and this will help with the expectorant effect. Ayan. And another is, if giving by syrup preparation, then avoid eating or drinking for 30 minutes before and after administration. No? If giving, avoid eating or drinking, no? The purpose of this class is, this is to prevent, no, the nausea and vomiting na side effect. This is to prevent the nausea and vomiting side effect. And that is it for our upper respiratory. I will take a 5-minute break first, then I will come back, no, for part 2, or drugs of the lower respiratory disorders.